The national guidelines are evolving over time. There's been a number of new agents that have been developed over the last couple of years. Certainly these agents have been developed, have had a different pharmacodynamic and pharmacokinetic profile. They're much longer acting agents. Therefore, we've been able to give these agents just prior to chemotherapy and have the agent last over both the acute and delayed phase. We're also looking at different ways to give the medication in antiemetics. They're looking at various sub-Q formulations, patches, oral therapies, and IV therapy. Again, trying to maximize the characteristics of the drug in order to make it most convenient for the patient so that they don't have to take multiple agents over that acute and delayed time frame, as well as to maximize how quickly the agents start to work so that they are covered in those acute and delayed time frames. We're trying to incorporate these new agents, at least into our own practice. Certainly we monitor when the new national guidelines come out, and then we go ahead and incorporate some of the new recommendations into our own clinical pathways so that our patients are getting the most up-to-date antiemetic therapy. As I mentioned, what's highlighted are some of these newer formulations, particularly in the neurokinin-1 receptor antagonist category, where a majority of the newer agents with these longer half-lives are being developed. When we talk about drug development of newer agents, one of the major developments have been really developing combination therapies where you have multiple agents in different classes in one formulation, whether that's an oral formulation or otherwise. This is a very interesting idea and way to prevent CINV because you really are covering multiple pathways with convenient administration of the drug. Certainly when we look at the pathways, this has been one of the areas that has evolved over time, knowing that CINV is not just driven by one neurotransmitter, that in fact there's probably multiple neurotransmitters in play at any one time. In addition to these newer formulations, we're also looking at individual chemotherapy agents and really reevaluating whether they should be classified as highly emetogenic or moderately emetogenic. One such agent is carboplatin. We're using carboplatin much more commonly now than cisplatin. It's older cousin, and we know that cisplatin is certainly one of the most highly emetogenic agents we have. And for years we thought carboplatin was much less emetogenic. With some newer data out there, we're starting to reevaluate that. More data needs to be obtained, but it looks like that use of an NK1 receptor with carboplatin is probably a reasonable approach in addition to cisplatin that we've known for years is highly emetogenic.